Next, we are going to hear from Dr. Shaida Khan, who is an assistant professor in the Department of Neurology at UT Southwestern Medical Center. She also serves as the medical director of the Neurology Clinic at Parkland Hospital in Dallas, Texas. Dr. Khan specializes in evaluating, diagnosing, and treating autoimmune neuromuscular disorders, such as myasthenia gravis, CIPD, inflammatory myopathies, as well as hereditary peripheral neuropathy, muscular dystrophy, and ALS. Dr. Khan earned her medical degree at UNT Health Science Center in Fort Worth, Texas, and she completed her neurology residency and neuromuscular medicine fellowship at UT Southwestern Medical Center. So, Dr. Khan, I'll turn it over to you and you can share your presentation.
Okay, great. Thank you, Nicole.
Mhm.
All right, well, I'm really glad to be here. Thanks everyone for waking up on a Saturday morning. And I have turned my pager off and my phone on silent. I'm on hospital service, and I told my team, don't contact me right now. So you all, I hope you guys can take home some pearls from this lecture. So let me share my PowerPoint. Okay, so my focus today is really going to be talking about advanced diagnostic strategies and tools that we use to really arm us and help us in diagnosing and even managing patients with neuromuscular diseases, and some best care practices toward the end of the presentation. These are my disclosures. So really, truly, with neuromuscular disorders, we've really come a long way as far as diagnostic testing, defining new disease processes. As you know, limb-girdle muscular dystrophies have like A, B, C, D, E, F, all the way to like almost Z. So we really defined new neuromuscular diagnoses and come up with new diagnostic tools to really help us with the diagnosis. And thanks to that, emerging therapies have come from that. And of course, our multidisciplinary care practices have evolved as well. So a combination of these things are really changing the landscape and how we manage patients with neuromuscular disorders. They're living longer lives, a better quality life, that's important, as well as really improving the lives of their family members around them too. Better understanding through research and diagnostic tools has really been the main driver toward these innovative treatments and new equipment designs. So some of the things I want to talk about is how antibody testing can drive us towards certain diagnoses, other comorbid features, associations with cancers and other disorders, and also treatment response. Imaging modalities, some new and emerging stuff that we're using as far as diagnostics, as well as emerging gene testing, and our multidisciplinary care practices and palliative care. So I'll touch on those toward the end of the lecture. So I won't go too much on the treatment advances because I think Dr. Sanka probably spoke about this or touched base on it. But really in the last 4 to 5 years, we've had a significant kind of exponential growth in the amount of neuromuscular therapies. And in particular, SMA, Spinraza, as you all know, was FDA approved in 2016. Last year, Zolgensma was FDA approved. And just a month ago, Evrysdi, which is an oral agent, was approved. And this has actually been approved for all types of SMA, including SMA type 2 and type 3. And there is some preliminary data showing that in adults up to age, I think the trial looked at up to age 25, that there was an improvement in the outcome measures that they did in all of them. So it's very early, but I did actually just get one patient enrolled in the Evrysdi, enrolled in the assistance program, and hopefully she's getting her Evrysdi soon. Myasthenia gravis, which is of course my area of research interest and clinical interest, very exciting time as far as the emerging therapies that are coming. As we know, Solaris is the first and only FDA approved treatment for myasthenia gravis, but there's a lot of new emerging therapies on the horizon. Duchenne's muscular dystrophy, you know, a lot of exon skipping, and also emerging later on is going to be CRISPR-Cas9, and of course ALS. Unfortunately, in ALS, there are some treatments, but not groundbreaking therapies. As you know, only edaravone and riluzole are thought to slow the progression of the disease, not to reverse or halt. But lots and lots of research is being done on ALS, sporadic and genetic variants of ALS. So again, this is not all encompassing. This is just a small list of just a few emerging therapies in neuromuscular disorders. So really, again, I think as we're elucidating these diseases better by understanding the genetics and defining new genetic diseases, I think we're kind of advancing and moving forward. X-linked myotubular myopathy is a congenital myopathy, and this is a new gene therapy that has been approved for those kids and babies. CMT, there are emerging gene therapies. None have made it. Of course, there are no commercially available gene therapies for CMT currently, but they're on the horizon. Myasthenia gravis, zilucoplan, efgartigimod, Immunovant, or RVT. Are immune modulating therapies that act pretty quickly and are thought to be safe so far in the preliminary data that exists. So, and then of course with Duchenne's, there's microdystrophin gene therapy, CRISPR-Cas9, necrotizing myopathy, ALS. There's a lot of treatment advances, and again, this is just a small list. So, in each of these domains in the MDA diagnoses, there are emerging diagnostic and treatment strategies. So it's a very exciting time to be involved in the care of patients who have neuromuscular disorders. So I want to talk about a case that I saw where diagnostic testing and our kind of, I wouldn't say it's advanced, but our, I guess, advanced understanding of how antibody testing and diagnostic testing can lead us to down the right path. So it was a young woman who was in her 30s who was referred to me for limb-girdle muscular dystrophy because of her pattern of weakness. She was falling, and she had several years of this proximal pattern, this shoulder and hip girdle weakness. However, things were a little unusual in this case because she progressed quite rapidly. And as many of you all know who have or know somebody close to you with limb-girdle muscular dystrophy, it's usually slowly progressive. It doesn't usually progress from walking to wheelchair, although it can. But it just seemed a bit unusual. And her CK level was high, but you can have CK elevations in muscular dystrophy. So her muscle biopsy was a little confusing because it had findings that said it suggested a muscular dystrophy, but there was a hint of inflammation on there. And the pathologist was like, well, it could be a limb girdle, it could be an inflammatory myopathy. So not super helpful. Genetic testing was negative. So, I had recalled in a conference, it seared into my memory that these patients that have a little bit more atypical features could have a necrotizing myopathy. And lo and behold, her antibody blood test for HMG-CoA antibody came back positive. So she, in fact, had an autoimmune necrotizing myopathy. So we started immunotherapy, and she's actually doing pretty good now. She's walking. She's still, gaining strength back with physical therapy, but she's made a dramatic improvement. So again, there have been several reports in the literature on cases of necrotizing myopathy, in particular HMG-CoA myopathy that was previously diagnosed as muscular dystrophy. And I think this is becoming more aware of the possibility of a diagnosis. So a lot of times inflammatory versus hereditary myopathies, diagnostically, they can be sometimes challenging to differentiate the two, especially if there's no family history. The exam, of course, guides us. That's my main tool I have in my diagnostic armamentarium is going to be my neurological exam. So the exam is very important. However, characteristic exam findings are not always seen in every patient. Not every, we always tell the trainees, not every patient reads the textbook. So you're going to not have patients present like textbook presentation. ENG can be nonspecific. Biopsy can also be inconclusive and nonspecific, as was in that case that I had. So antibody testing can really answer a few questions for us. For instance, are we dealing with a treatable diagnosis? What is the prognosis of this? Certain inflammatory myopathies have a better treatment response. Some have a more poor response to immunotherapy. Some have a higher cancer risk associated with it. Some have other autoimmune and mixed connective tissue diseases associated with it, lung issues, cardiac involvement. And also, is the patient responding to treatment? That's something that can be answered with not only antibody testing, but of course gene testing and also muscle imaging, looking to see, is there residual inflammation? Is there muscle loss? So there is muscle weakness, but it's from muscle loss and not inflammation. So we don't just keep escalating immunotherapy. So really, truly, our advanced diagnostic testings have helped us kind of elucidate the diseases more, help us to guide patients in our conversations and how they might look in the future, and also kind of what other associated risks that they have. So some of the best practices, as we know, for inflammatory myopathy, muscle biopsy is definitive. And even if there is a confirmed inflammatory myopathy on muscle biopsy, I still perform antibody testing for all inflammatory myopathy patients because, again, it can kind of guide which treatments and what other associated conditions need to be screened for. Get a chest x-ray to look for interstitial lung disease and malignancy like cancer, especially for dermatomyositis. Age-appropriate cancer screenings otherwise are okay, like colon cancer screening, colonoscopy, mammogram for women. And of course, the treatment is steroids is the standard of care, steroid sparing agents, depending on the type of inflammatory muscle disease you have and how you respond to different treatments. We look at your patient's examinations and monitor their CK levels. So here are just a few examples of some of the antibody testing. For instance, MI2 antibody is associated with dermatomyositis and has a favorable treatment response. And there's a lower risk of cancer, while we still do cancer screenings less aggressively. Whereas NXP2 and TIF1 gamma has a higher risk of cancer. So I'm going to be more diligent about screening patients who have those antibodies with to see if they have an underlying malignancy. And then MDA5 is an antibody associated with a very aggressive form of dermatomyositis, and they have rapidly progressive interstitial lung disease that's really important to identify so we can get them to the appropriate specialist. And then, of course, NT5C1A is an antibody associated with inclusion body myositis. So if there is an inflammatory myopathy but has the IBM picture, it looks like inclusion body, then immunotherapy is not going to be helpful for that, as we know. So again, antibody testing can really help guide our conversations and our discussions of treatment. So going on to hereditary muscle disorders, genetic testing, of course, is going to be vital for the diagnosis and management. And I think we've really come a long way with our gene testing, advanced techniques, identification of new gene mutations, defining diseases. So a lot of times patients will get frustrated because they might have what this is called a VUS. You might have heard of that, a variant of undetermined significance. Well, lots of times I say, well, maybe this is undetermined now, but if lots of other patients, if we're sending more gene testing and more patients are having these variants and look clinically the same, then we're not going to call it, or the scientific community shouldn't call it VUS anymore. And in the last 10 years, they've really defined new genetic muscle diseases based on the characterizing the gene mutations on the gene test. So I think it's important to get gene testing on everyone. And we now, again, have identified mutations in over 500 genes. And so we're defining new diseases. And it's important to do that, right? Because you want to be able to target therapy appropriately. And as gene therapy is emerging, we want to be able to target the right thing so we can restore the reading frame or the repeat disorder or whatever is the underlying cause of the genetic muscle disorder. So it is important for differentiating the type of neuromuscular disorder, the pattern of inheritance. Is this autosomal dominant? Is this autosomal recessive? What are the risks or the concerns for family members? Progression and prognosis, and also screening for other disorders such as cardiac disease. As many of you know, those who struggle with Duchenne's muscular dystrophy, Becker's muscular dystrophy, Emery-Dreifuss muscular dystrophy do have prominent cardiac involvement. So that's going to prompt me to refer my patient to a cardiologist. And at our institution, we have a cardiomyopathy specialist who takes care of patients with muscular dystrophy. It's cost effective and safe. It is really, when I started training genetic testing, I remember ordering a panel on someone and it was $10,000. Which is insane. Insurance wouldn't cover it. I mean, $10,000, that's insane. So it's really become a lot more cost affordable, not only out of pocket, but of course, insurance providers are covering the cost of gene testing more frequently now. As far as guiding discussions, preventing unnecessary treatments, because then the flip can happen. They've been diagnosed with an inflammatory myopathy, and I've seen that as well, and they're not responding, they're getting weaker, and in fact, they have a hereditary muscle disease. So to reduce their risk of immunosuppression, it's important to get them off immunotherapy that they don't need. And then, of course, family planning, and then participation in clinical trials. So if you know you have muscular dystrophy from your family members, I still recommend getting gene testing, because if you want to be involved or get enrolled in a clinical trial, genetic testing confirmation is going to be important for that. So I really do think that the next frontier of neuromuscular disorders is going to be gene therapy. We've done a lot with immunotherapy, but I think that the next frontier is going to be gene therapy. So here are some of the free gene testing programs available for diagnosis of certain neuromuscular disorders. The Lantern Project, which is done through Perk and Elmer Genomics, has a wide range of free gene test panels. Invitae also has free muscular dystrophy testing, lysosomal storage testing, periodic paralysis testing, and SMA gene testing. And then the Rare Genomics Project, also through collaboration with the MDA and the Jane Foundation, also does free gene testing. So again, it's much more affordable and free. So, I always get asked this question: how far away are we from gene therapy? And many times people have always, my mentors and everyone said, oh, probably decades. But really, I think we're not that far off. So Dr. Olson, who's pictured here, is leading a team of scientists from all disciplines to come up with a treatment, hopefully cure, for Duchenne muscular dystrophy. And his life's work has been CRISPR-Cas9. And this article was recently published, and they did show that CRISPR-Cas9 corrects DMD exon 44 deletion in mice and human cells. So I think this is very exciting. He's given several Grand Rounds talks, and I think that we're not too far off. So I just want to talk about muscle MRI utility. We don't use this too often, but it's non-invasive, and it can be a very helpful tool, particularly if we have patchy inflammation in the muscles. We can see which muscles are more inflamed and have more signal change, and target the biopsy to that muscle. So we make sure that our diagnostic yield is increased. There are particular patterns of muscle involvement with certain myositis. So if the clinical picture is a little confusing and you get MRI, there are certain muscle groups that are more affected in some inflammatory myopathy. So it just kind of helps us define the disease a little bit more. And it also looks at disease activity. It's important. Are we treating this appropriately? Is there still active inflammation? Or this person, comes to me who's still weak and is on immunotherapy. Is this fixed weakness? Is it from old muscle damage, or is there active inflammation? So muscle MRI can help look at the extent of the disease and damage that has occurred and is occurring. So cardiac imaging, really, this is something that I was doing research on for a couple of years. And cardiac MRI really is the gold standard for evaluating heart function in patients with certain neuromuscular disorders. It's a much more sensitive and accurate method of assessing structure and function. And some of these articles here are just a few that highlight that the ventricular function that was detected normal on an echo was actually abnormal on a cardiac MRI, and there's a poor correlation between echo and MRI. And particularly in Duchenne muscular dystrophy, where our cardiologist, Dr. Mammon, guides his treatment based on, is there cardiac involvement or is there not cardiac involvement? So it really is a better diagnostic tool to detect and quantify heart muscle damage. Ultrasound for peripheral neuropathy. This is really new. We just got an ultrasound machine in our clinic, and many of us are going to start learning and training how to use it. So this is an emerging tool. I know that some academic centers are using this and for diagnosis, but we are currently, I think many places are not currently doing this for diagnosis, but it's an emerging tool and it's exciting because of course it's another non-invasive tool. It can help with diagnosis of particular neuropathies, CIDP, CMT, vasculitic neuropathy. It can guide testing and treatment. It's cost effective, non-invasive. You just quickly get the ultrasound. And just like an EMG and nerve conduction study, it's an extension of the neurological exam. So just like an EMG nerve conduction kind of helps us, ultrasound can kind of be a complementary tool. And if you, again, I don't want to go too much. Oh, I took a slide off. Bummer. Well, I had some pictures where it just showed different ultrasound findings in CMT, CIDP, so you can characterize certain patterns of nerve abnormalities on an ultrasound. So this is exciting, and I'm personally excited to start training and learning how to do this. Myasthenia gravis, very exciting time for the treatments for myasthenia gravis. Our current therapies are effective, quite effective, but have a lot of side effects, take a long time to work. Thymectomy is, of course, indicated for those with generalized myasthenia gravis, and exercise. And yes, exercise actually does improve myasthenia gravis. There's data showing that patients who were involved in an exercise program had significantly improved levels of fatigue. And there was one study that actually showed that their myasthenia gravis outcome scores were getting better. So I encourage all my patients with myasthenia gravis to exercise because it will help your underlying disease. We're discovering new antibodies. The LRP4 is an antibody that some people might be familiar with, but it just became commercially available a few years ago. This is a newer antibody that was discovered. So about 2 to 50%, that's a pretty wide range, of patients with, quote, double seronegative MG actually have positivity to LRP4. So seronegative for both antibodies, acetylcholine and MuSK antibodies. And new therapies are emerging where they're targeted, they're specific, they work quicker, there's less side effects, and they're safe, hopefully. So I think it's a little too early to say that, but we'll wait to see what the studies and the data show. So I'm not going to go through every single pathophysiologic mechanism of myasthenia gravis, but as you can see here, the immune system is very complex. And as we're understanding myasthenia gravis more, we see that, for instance, complement, there's a big role in complement activation for patients with myasthenia gravis. So we are developing complement targeted therapies. And then, of course, modulating the antibody response and also the clustering. So very exciting time for treating myasthenia gravis. Neuromuscular disorders are not just a neurological disease. As many of you are aware, neuromuscular disorders can affect other organ systems. And so kind of the comprehensive management of clinical problems for the neuromuscular population is complex. And it really is a team-based effort. Really, an interdisciplinary treatment approach is critical. We have great collaborations with our subspecialists who help manage the extra neurological manifestations of the neuromuscular diseases. Our physical medicine rehab doctors, our orthopedists, our cardiologists, our pulmonologists, of course, rheumatologists if there's an inflammatory myopathy and association of connective tissue disease, physical therapy, occupational therapy, speech therapy, nutrition. And I know that I'm excited that somebody's giving you guys a lecture because this is crucial. This is important as far as the overall treating the patient as a whole, not just the muscle or the nerve disease, and psychology and social worker. So really it's just kind of a team of people that help provide the best care. Non-surgical treatments, Botox was FDA approved not super long ago, but relatively recently. Botox was approved for spasticity in the lower limbs for ALS. There's special bracings. There's other equipments that have kind of emerged as lighter, more user-friendly, and it's definitely led to a lot of patients saying, I can actually, function more in my day-to-day activities. Speech therapy and nutrition are very helpful for us. And so again, just to highlight, we really do need a team of people helping take best care of our patients. And they tend to feel better, like they know more and they have more, they have an active role in their disease. So, all right, nutrition and feeding, just won't go too much into this, but I do want to mention and highlight that early on, swallowing issues can be managed with the help of an experienced speech therapist and a dietitian. So avoiding problem foods, positioning when eating, changing to thickened liquids can really help patients feel better about eating and not feel distressed and uncomfortable, and make sure that they're getting the right amount of nutrition that they need. Again, of course, depending on the diagnosis, it is important to discuss a feeding tube. This can happen in stages. I've had many people be very resistant to the discussion of a feeding tube. And it's 100% every patient's right to choose what's right for them. But there's misconceptions of what a PEG tube is and what it's used for. You can still enjoy foods by mouth and eat. However, the nutritional demands you need and the amount of water you need can be supported through the PEG, and you can feel better because malnutrition and weight loss are, particularly specifically for ALS, associated with poorer outcomes and shortened survival. And when you're not getting enough nutrition and water, you tend to feel crummier. So just highlighting that this is it is actually sort of kind of a treatment, not of the ALS, but treatment of the whole patient. And coughing and choking on food can be very stressful. It takes a long time to feed. The arms are weak, so it can get very emotionally and physically exhausting. So we tend to have these conversations earlier on just to kind of think about it and have the patients discuss it with their loved ones and family members. Multidisciplinary care for pulmonary care really is going to be key for people with respiratory issues. And non-invasive ventilation is one of the greatest advances in treating neuromuscular disorders. We've come a really introducing earlier ventilation in patients who need it has led to a significantly improved quality of life as well as survival. And there was a trial in ALS that showed that there was a median survival benefit of about 7 months difference in patients with good bulbar function. So it's important to talk about not just extending life, but improving the quality of life. Because of course, most people don't wish to just extend life. They want to improve the quality and substance of their life. Palliative care is a topic a lot of people hedge on discussing, but I think it's very important. And I do think that there's misconceptions of palliative care. It is not just for terminal diagnoses. It is for patients who struggle with a significantly disabling diagnosis. And its aims are in comfort care. And I do, depending on the diagnosis, of course, not right at the onset of the discussion because that's not appropriate, but later on kind of slowly and gradually introduce different topics of end of life care. They're tiered discussions. I don't discuss everything all at once with the patient because, and I kind of gauge which patients want to talk about it and it's on their time. And that's very important to have these discussions in a time appropriate fashion. Palliative care can really assist with symptom management, family support, spiritual care, which medications are going to be helpful, which medications are not indicated, advanced directives, oops. And then hospice care is an option in the later stages. And again, this is something that can be introduced gradually. It can be a respite for caregivers. Advanced directives are going to be important, and appointing a power of attorney to help with supporting the patient's wishes. So these discussions have been had, and people feel better about a direction, a clear direction, allow for some more peace and acceptance. And that's it. I'll take questions now.
Thank you very much. We did get some questions that have popped in. What is the status of CRISPR research on those with autosomal dominant neuromuscular disorders?
That's a great question. So autosomal dominant disorders, there's a lot of them, and it depends on the gene mutations. So sometimes there's point mutations, sometimes there's repeat disorders. So the repeat disorders, such as myotonic dystrophy, are harder to target, and there's so many different downstream effects of the gene mutation with myotonic dystrophy. So it's a little harder. So I think CRISPR-Cas9 is definitely emerging, but not for all autosomal dominant disorders. But yes, autosomal dominant is the pattern of inheritance, but there's different pathways and different gene mutations that are affected. So CRISPR-Cas9, as you know, is just DNA scissors. It goes toward a specific area, cuts the abnormal part out, removes it, and it restores the reading frame. So a lot of point mutations, or kind of mutations that are on one area, can be cut out. Now, I think you have to get more sophisticated to go, if there's different gene targets, to go and cut different areas out, or longer ones. For instance, Duchenne patients who have longer exon deletions, that's going to be more challenging to treat with CRISPR-Cas9, but it's emerging.
Okay. And I know we had mentioned VCP disease earlier with Dr. Sanka, and this person has typed in again that the VCP disease is often misdiagnosed as limb-girdle.
That's correct.
And she's asking, what is the testing process for those with limb-girdle? And is it possible that some of the subtypes of limb-girdle are actually the VCP gene mutation?
Great question. So VCP gene mutation is interesting because it can actually it can mimic not only muscular dystrophy, but it can also mimic ALS. I actually had a patient who had mixed features of muscle disease and motor neuron disease, and ended up being having the VCP mutation, had frontotemporal, like some dementia and frontotemporal. So there's a clinical spectrum of patients who have the VCP gene mutation. But the testing for that, you can actually identify the gene mutation on the limb-girdle muscular dystrophy gene testing panel. They do check for the VCP mutation. And you can also identify this on muscle biopsy. But the gene testing, there is a VCP gene testing that's available on the limb-girdle panel.
All right, that's good to know. Should all patients get a cardiac MRI, or when do you recommend someone to get a cardiac MRI? Once a year, or is that on an as-needed basis?
That's a great question. Depends on the diagnosis. If this is specifically for muscle disease, inflammatory muscle disease, or limb-girdle, or any genetic muscle disease, depends who you ask. I say yes, get cardiac imaging on everyone, because we're defining new diseases. So for instance, for a cohort of patients that we were previously studying that were thought to not have cardiac involvement, actually cardiac MRI is showing that there is some cardiac involvement. There's cardiac atrophy, which is a new kind of a new mode of abnormalities that we're identifying on patients with certain muscular dystrophies. So I would say yes. I
Mhm.
would say yes for cardiac imaging on all patients with muscular dystrophies. It has to be with people who feel comfortable with muscular dystrophy, and understand the management of cardiomyopathy in patients with neuromuscular disorders is very different from the
Mhm.
management of cardiomyopathy in people with ischemic cardiomyopathy or coronary artery disease. So
Sure.
it's
I would
really,
ask too that person to read if they want to type in their diagnosis that they were inquiring about the cardiac MRI. Please do so. Can Botox be used all over the body? Can it be used for weak neck muscles? Sorry.
it can. So Botox is FDA approved for cervical dystonia, but I strongly recommend against the use of any neuromuscular blocking agents like Botox in patients who have neuromuscular disorders, especially myasthenia gravis, and certain muscle disorders as well. Because then you're going to lead to, if you inject the posterior neck muscles, you're just going to have head drop and you're going to have weakness, and it's probably going to lead to more disability. However, if there's a lot of spasticity and increased tone or dystonia, then yeah, Botox can be used in the neck muscles. But it would depend. Usually, primarily, Botox is used in the large leg muscles and the arm muscles to help with the tone and the
Oh,
spasticity.
okay. The person did type in for the cardiac MRI. She has limb girdle 2J.
Okay. I would say yes.
Okay. Thank you. Does CMT1A affect other organs systems?
I'm sorry, say that again?
Does CMT1A affect other organs systems?
So no, but it caused as a direct cause of the gene
Mhm.
mutation. No, CMT
Okay.
is isolated to a peripheral nerve dysfunction, but it has downstream effects. So you can get hip dysplasia and hip
Mhm.
abnormalities, and a lot of osteoarthritic changes in the low spine and the hip area. So that is an associated feature of CMT. And then some CMTs actually have associations of epilepsy. So there's some
Okay.
CMTs that can actually affect the central nervous system as well. It's very rare, but primarily CMT, for instance, 1A and 2A, the more common CMT gene mutations, really just affect the nerves.
Okay. And I know we have a genetic counselor coming on later today, and I know she's going to do a whole presentation on genetics and what that entails. But we did have a person type in, what kind of gene testing do you personally recommend? Whole exome sequencing?
No. So yes, whole exome sequencing can be used, whole exome, whole genome sequencing can be
Mhm.
used in certain patients, but really it depends on what we're looking for. And again, that's where, again, our examination, our history, just our neurological investigative skills come in, because that's what's going to guide which gene therapies we get. For instance, if you have a very clear pattern of distal weakness or X, Y, and Z, then I'm not going to get all of the gene tests. I'm going to start focused
Okay.
and then expand. So starting big, I wouldn't do. I start usually as focus panels. And some of the panels are really all encompassing and have like 100 genes that they check for, even though I'm really in my mind looking for a few.
Hmm.
I start off with certain panels of gene testing. So there's a limb girdle panel, or if I know that a patient has a hereditary ALS, I start off checking the C9orf72 gene mutation, and I don't check every gene mutation associated with ALS. I check the much more common one, and when that's positive, then that's it. We have our answer. If not, then I'll expand to check the other gene tests. So it depends on the diagnosis, and it depends on the clinical suspicion. So yeah, there have been complicated cases where I've had to get whole exome sequencing because I really strongly felt that this was genetic,
Yeah.
and panels didn't show any gene mutations.
Interesting. Okay. Will the emerging gene therapies for CMT1A be age restrictive? My wife is 51, son is 30, my daughter's 26, all with CMT1A. I wonder when it's available if our kids can benefit from it or if they are too old already.
I think so. I don't see why there would be an age restriction. I think that they might even use it as early as, I mean, in childhood, if they do develop these. Again, safety is going to be a big question I always have, is exciting emerging treatments are exciting because
Mhm,
they work, but what's the safety?
mhm,
So I think that they need to determine the safety. And of course, a pediatric body is different from a adult body. Um,
mhm,
so I think that they need to separate the trials and look at patients with childhood onset and look at patients with adult and define, because they're different and the progression
mhm.
is different and they're in different stages of the disease. So, but I don't think it's going to be restrictive. I think it's going to be all encompassing.
Okay, well, that's hopeful. Another question is, my daughter has myotonic, and I am the carrier of the mutated gene, but not mutated enough to affect me when she was diagnosed 19 years ago. As I have grown older, I'm having weakness in my core muscles and legs. Is it possible that the weakness is from the mutation?
Yes.
Okay.
And I, with myotonic dystrophy, um, I would screen for cardiac issues
Okay.
in the mom.
Okay. This person says they were diagnosed with limb girdle in 1985. Recently, through genetic testing, I learned that my dystrophy is caused by a mutation of the ADSSL1 gene. Is this still considered a subtype of limb girdle?
It's not, it's not a common one. It's not one that's been well defined. But again, I think many subtypes are being discovered, and it depends who you ask also. But no, that's not a common one that I'm aware of. That's accepted as a common limb girdle muscular dystrophy.
Okay. All right. I am not seeing any other questions. So thank you very much for your time this morning. I appreciate it.
Thank you. Thanks for having me.
Have a great rest of your weekend.
You too. Bye, everyone.